The new era, monoclonal antibody therapy. We have spent decades treating parvo by just holding the line, giving fluids and waiting for the body to fight back. But recently, the game changed. We now have a weapon that doesn't just support the patient, it attacks the virus. The paradigm shift. The old way. Traditional care is supportive. We fix dehydration, we stop vomiting, we prevent sepsis, but we do nothing to the virus itself. The new way, monoclonal antibody or mAb therapy. The goal. This provides targeted antiviral activity. It neutralizes the circulating virus before it can destroy more crypt cells or bone marrow. The impact. It is most powerful when used early. If we catch the virus while it is still circulating in the blood, or viremia, we can significantly reduce the viral load, shorten the hospital stay, and improve survival in those high-risk puppies. What is a monoclonal antibody? If the immune system is an army, these are the special forces. The definition. They are laboratory-engineered immunoglobulins designed to bind to one specific thing. The target. In parvo, they target the viral capsid protein. By binding to the shell of the virus, they physically block it from entering the host cell. If the virus can't enter, it can't replicate. Why is this better than plasma? We used to give hyperimmune plasma from vaccinated dogs. The problem with plasma. It is messy. The antibody levels vary from bag to bag. The advantage of mAbs. Standardized potency. Every dose has the exact same amount of neutralizing power. Immediate immunity. It provides passive immunity instantly. Host independent. This is crucial. A parvo puppy's immune system is often destroyed or leukopenic. These antibodies work regardless of the puppy's ability to mount its own response.
Monoclonal antibodies functions as a biological firebreak. The mechanism. The monoclonal antibody enters the bloodstream and hunts down the free-floating parvovirus virions. It binds tightly to the viral capsid. Once bound, the virus is physically incapable of attaching to the host cell. If it can't enter, it can't replicate. It effectively sterilizes the virus in the blood. Halting versus reversing. This is the most critical concept for clinicians to understand. What it does do, it halts ongoing viral replication. It stops the fire from spreading to new crypt cells or new bone marrow precursors. What it does not do, it does not reverse existing damage. The crypt cells that are already necrotic are gone. This is why early administration is key.
We have the weapon, but when do we pull the trigger? Monoclonal antibodies are not cheap, and they are not for every mild case. Strategic use is key. The golden rule: use it fast. The therapy is most effective when administered within 48 to 72 hours of clinical onset. Why? Remember, this drug targets free-floating virus. Once the virus has already destroyed the gut lining and the marrow, the damage is done. You want to catch the virus during the viremic phase, when it is swarming in the blood but hasn't finished its destruction yet. Who gets the drug? The high-risk puppy. The 10-week-old Rottweiler with a positive SNAP test. The bad blood. Patients presenting with severe leukopenia or rapid progression. If the white count is crashing, you need to stop the viral assault immediately to save what little marrow is left. The setting. This is a game changer in the ICU or referral setting where owners are committed to advanced care and want to do everything possible to shorten the hospital stay.
The protocol. This protocol is straightforward. One and done. It is a single intravenous IV dose. No redosing in majority of cases. No constant rate infusions. It is weight-based. Weigh the puppy accurately on admission and calculate per the manufacturer's chart. The compatibility. You can give this on the day of admission, right alongside your standard stabilization. No conflicts. It is not contraindicated with your IV fluids, your ampicillin, or your meropitant. You don't have to stop one to give the other. The crucial reminder. This is adjunctive therapy, not a standalone. It must be part of the full bundle. IV fluids plus antibiotics plus antiemetics plus early nutrition plus the antibody. It makes the standard care work better, but it does not replace it.
Let's wrap this up with the safety profile and the bottom line. Safety, a clean profile. The good news? This drug is generally very well tolerated. Hypersensitivity is rare, and it does not cause immunosuppression. The administration. You rarely need pre-medication. Just give it slowly, IV. Side effects. Occasionally, you might see a transient fever or lethargy, but compared to the disease itself, these are negligible. The limitations. Managing expectations. Not a miracle for the dying. If the gut is already necrotic or the puppy is septic with a temperature of 94 degrees Fahrenheit, this drug won't fix that. It stops viral replication. It doesn't resurrect dead tissue. The cost. It is an investment. It adds to the upfront estimate, but remember, it likely saves money on the back end by shortening the ICU stay. Immunity. It confers temporary immunity. It does not replace the need for vaccination later. Prognostic impact. Who wins? The best candidates. Puppies caught early with mild leukopenia. If you hit them with monoclonal antibodies plus fluids on day 1, they often turn the corner fast. The reduced impact. Puppies presenting late, more than 72 hours, with profound neutropenia or hypothermia. The virus has already done its damage. Infection control. Don't drop your guard. Just because you gave the antibodies doesn't mean you can skip the bleach. Isolation protocols remain mandatory. The puppy is still shedding, just potentially less. The new standard. Monoclonal antibodies are rapidly becoming part of the modern Parvo protocol in ERs and specialty ICUs. They are not a silver bullet that replaces nursing care, but they are the first tool we have that actually fights the virus itself. The takeaway. Diagnose early, treat aggressively, and if the budget allows, neutralize the virus before it destroys the host.